Ojaswi Acharya from ACF-Nepal. I come from Nepal, where I do CMAM program. ACF-Nepal, we do CMAM in one of the district together with the government of Nepal. Apologies from government of Nepal. The representative, he was supposed to be presenting a half of the presentation, but he couldn't attend the conference because of some visa problem. It didn't arrive on time. So I'll be presenting on his behalf as well as from ACF behalf. Today I'll be talking about government's plan to scale it up, the CMAM program in Nepal, and how government has incorporated the treatment of CMAM in the national protocol and national multi-sectoral nutrition plan. I'd like to move background on Nepal and the challenges that it has. In Nepal, around half of under 5 mortality is associated with malnutrition. It is noted that there are geographic areas of food insecurity and that sanitation and hygiene are unsatisfactory in most of the country. Certainly, the combinations of factors that lead to child malnutrition have not been effectively addressed in the past decade. The available indicators demonstrate that acute malnutrition in children under 5 is seriously high in Nepal when interpreted as per the WHO crisis threshold. In the absence of in-depth research on food security and child development in Nepal, the reason for serious incidence and prevalence are difficult to explain, particularly in the view of the positive progress on the Millennium Development Goal indicators. Over last decade, the prevalence of severe acute malnutrition has either increased or remained constant, while prevalence of GAM has fluctuated around 10%. That is, you can see the 11% average, which is the serious level of malnutrition nationally. If you look at this slide here, you can see Nepal is divided into 3 ecological regions: the mountains, hills, and terai. And then there is various different reasons why there is high number of malnutrition in mountains and in terai. Like we have different reasons. We cannot have. Nationally, there are different reasons for the higher number prevalence of malnutrition, and we, as ACF, we currently work in the Eastern Terai region. Can we move on? Different vulnerabilities in Nepal is acute malnutrition has remained stagnant over a decade. National average, as we saw, it was 11%, but when we look at the mountains, it was like 27% in one of the assessment, whereas even in Terai, there was 21% of GAM. There are various disease outbreaks, poor feeding and care practices, poor hygiene and sanitation, and political instability, armed conflict for years, and disaster prone. All this contribute to the high level of acute malnutrition in Nepal. Can I move forward? Another slide. Yeah. Yes, now talking about the history of CMAM. CMAM in Nepal started in 2007. Then a feasibility study was conducted, and as such, in 2008, it led to the approval of emergency nutrition policy, which included CMAM piloting. Meeting on CMAM protocol and implementation framework was done, and a baseline survey in 5 districts was done. In these 5 districts, were selected on the basis of mountains, hills, and terai. And on these, there were training conducted, implementation in 5 pilot districts, and then there was a global evaluation of CMAM in multi-country evaluation, which also proved the success of implementation of CMAM in these 5 pilot districts. With the success of implementation in these 5 districts, we moved on to IMAM. Like CMAM was changed into IMAM, which was a comprehensive package of including moderate acute malnutrition treatment as well as infants below 6 months. We are currently in the phase of developing and revising IMAM guideline protocol and the training materials, and now the plan is to scale it up to 6 districts from 2012. So currently in Nepal, out of 75 districts, we have got CMAM in 11 districts, and by the year 2017, the plan is to cover 50 high burden districts in Nepal. Thanks to the government has come up with multi-sectoral nutrition plan. This is a multi-sectoral nutrition plan in line with the scaling up nutrition. So to scale up the nutrition activities, the National Planning Commission is the lead who has come up with this framework. And if you see, there is a, can you just press? Yeah, Sam better managed is one of the points highlighted within this framework, and that means like Sam has been identified as integral part, one of the integral part of life-saving intervention within the multi-sectoral nutrition plan. So this multi-sectoral nutrition plan has got all the ministries, 5 different key ministries, that is Ministry of Health and Population, Ministry of Physical Planning and Work, Ministry of Agriculture and Cooperatives, Local Development and Education. And since the lead is the National Planning Commission, it is under the Prime Minister's office, and a high-level steering committee is responsible for the implementation of this in different districts. In 2012, as I already mentioned, 5 pilot districts was there. Then 6 more was added. So right now, currently, we have 11 districts which has got a CMAM program. Now, government will be starting another 5 districts this year, and likewise, like they have allocated, they have a plan. Government has this draft plan on how they are going to scale it up to 50 different districts, and and in 2013 they will adopt the new IMAM guideline, which is under the process. So this is the map of Nepal where all these yellow, the district in yellow, they highlights the district, the pilot district, like Mugu in the up, you can see Mugu, which is in the mountains, and then in the hills there are 2 districts, Acham and Jajarkot, and then there is Bardia and Kanchanpur. So like they are divided, they are categorized according to the ecological reason. And then another, this blue area that you see is the scale-up district after the lessons learned from the pilot district. And now all these 11 districts and now upcoming scale-up district will be termed as IMAM and not the CMAM. So it will have more components to it. Right now, this year, looking at the data, the recovery rate nationally of all 11 districts is 88%. That's 0.2%, and default is 77%, which is all within this fair standard. So what is the difference between CMAM and IMAM? So that was the CMAM model had inpatient treatment, wherein inpatient treatment was broader defined in the IMAM, where they categorized between the rehabilitation and the hospital-based treatment. Then the integration of other programs, other health programs, the links are more like for example, the volunteers' involvement, the health facility, and other have more government programs integrated within this framework than the CMAM. And in RUTF, previously it was said like RUTF supply chain management would be there, but now they are looking at the possibilities of RUTF production, local production of RUTF, and this year UNICEF is going to test the feasibility of RUTF production locally in Nepal. Yeah, and also another inclusion in IMAM is the treatment of MAM within this framework. So treatment of MAM, treatment of under 6 month children is also included in this integrated management. So ACF, just to give you an example where ACF works, is we work in Terai district where along with the CMAM we recently did a coverage assessment where we had 40.9% of coverage of our program, and this was done when our program was 8 to 9 month old. So that was quite young. How we work is we support government to implement CMAM in the district. So we basically do health system strengthening. We try to work on each pillar of the health system. We work for 3 years, and then we exit strengthening each pillar of the health system. Till date, we have screened almost 50% of the children in the district. More than 3,000 SAM cases has been treated in last 15 months. We conducted a smart survey, and one of the striking finding that we got from our survey was like we all base our intervention on the information provided by the government surveys like demographic health surveys, and we intervened in the area where there was 10% of global acute malnutrition plus aggravating factors. When we did our survey, we found the number to be 21% of global acute malnutrition. So there are gaps, like we need to support government more on the research, more to find out the data on the prevalence of acute malnutrition specific to the burden of the country. And we do capacity building of all the Ministry of Health staff in the district. At present, the district has about 16,000 under 5 children with severe and moderate acute malnutrition. And during the implementation of this program, ACF faced the huge complexity of the root cause of this phenomena. So it was not a single malnutrition cause, but there were issues like migration and other issues which all needs to be tackled. Yeah, we are working towards saving life of the children in this district, and we continue doing so.